Hello?
Hey,
Hey.
I just wanted to quickly ask about the agenda and if you had any information on Andrea's presentation.
Yeah, I mean it's updated on the slides, but she's talking about family systems and youth substance use.
Okay, family systems and youth substance use. And I'm so glad we got the case presentation. Are we gonna start off with just like that brief introductions, just your name and
Yeah.
and the role on the team, something
Yep.
like that?
Yeah, we'll always do introductions because the assumption is that there will be people there that aren't always there, and it's to like foster, getting to know each other. So yeah, we'll always do introductions.
Okay.
So the agenda is basically always exactly the same.
Okay.
And
And
go ahead.
go ahead. No, go ahead.
Oh, just like if people were anticipating that it was going to be Gonzo, you can just speak briefly to the fact that Andrea stepped in his place and that he'll be doing his another day. So.
Okay. And we just have to confirm that he can do it next month. I'm assuming you probably have.
I haven't heard from him because I think he's busy with other things. But,
yeah.
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 No, I'm already in the room waiting. Hi.
Hey, Carissa. Hold on, the dog just barged in.
No worries. I figured I would just give you screen sharing abilities so that you can control your own slides.
Perfect. Thank you. Actually, I should pull those up real quick before we get started. Hold on here. Yeah, like you can keep talking. I'm like, oh yeah, just remember.
So I'm just gonna make you a co-host so that you can share.
Okay.
Andrea, you saved the day. I'm just gonna.
Thank you so much for doing this.
Well, I'm happy to do so, and like I said before, I just kind of after you asked it, I'm like, oh, I got to go back to my other presentations and see if I have anything that will work. And then I found this other one that was aimed more at parents, but I thought a lot of the info was relevant, so I just kind of tweaked a few things, and hopefully it works. And it's a little bit off the cuff, but we'll go with it.
We'll definitely go with it.
All right.
All good.
You guys have a good holiday weekend?
Oh, it was nice.
Yeah.
How about you?
Yeah, it's nice to have a little extra time, and
yes.
Nothing exciting. It was quite boring actually, but it was kind of nice to be boring for a while.
That's the thing. Sometimes that's really nice. And Elizabeth, I have to say a shout out to you as well. You also saved the day.
No problem.
So I really, truly appreciate that.
Absolutely.
Hopefully we'll have some more people hopping on.
Give people some more time to show up. 8 a.m. is early.
It's early.
It's weird seeing my name like that. I just got married and it's just like I'm still getting used to my new last name.
It's a big change, isn't it?
It is a huge change, and it's like, you know, I was an older bride, like I'm out of my 20s, so it's like I've had my entire adult life as well, and so it's a big change. I just got my license in the mail yesterday with my new name on it, so my professional license.
Nice, nice. Well, eventually it will become old hat, but you know, for
Yeah.
the first few years, I feel like it is weird.
Yep.
Got a few more people.
Or we can wait until around 5 or so after before we
Yeah.
get started.
Well, should we get started? All right. Welcome,
think that's
welcome. I appreciate everybody coming today. Hopefully we'll have a few more people kind of trail in on this early morning. Let's start out with some basic introductions. If you'll just say your name, your team, and your role on the team, and we'll go around and just do a brief introduction. There's Melissa. So I'm Piper Meyer-Kalis, and I'm an IRT on the mHealth Navigate team. And I'll throw it over to Carissa. Oops, Carissa, you're still muted. There you go.
I'm Carissa. I've been working with Piper for about 5 years now. And I'm super happy to see everybody this morning. And I will pass it to Elizabeth.
I'm Elizabeth Havish. I'm the IRT on the HOPE program. And I will pass that to Nancy.
Morning, everybody. I'm Nancy. I'm the family peer for the HOPE program and the Navigate teams. Good to see everyone. I'll popcorn to Claire.
Morning, I'm Claire. I'm the Supportive Employment Education Specialist with the HOPE program. We'll pass it to Melissa.
Morning, I am the C with the U of M team. Good morning. And I'll pass it to Andria.
Hi, I'm Andria Botzet. I'm a marriage and family therapist in the department. I will pop it over to, I don't know who it is, 878173 or 8, yeah. I don't know whose ID that is. So pop in and tell us who you are.
Hi, can you guys hear me?
We can hear you.
Oh, sorry. Anyway, sorry, I'm Anne Romine. I'm sorry, I don't have my name up there. I'm the Hope nurse. So,
Excellent. Welcome. So glad you're here.
yeah.
Hi, Anne. Good to kind of see you.
Hi, Andrea. Sorry.
And I think we only have one left, Cersei. I hope I said that right. So correct me if I'm wrong.
Yes, Saoirse, like Sears.
Saoirse. Got it.
So I'm Saoirse. I'm the other IRT on our team at Hennepin Healthcare Hope.
Excellent. I think we got everybody. So I have to say we had a last minute replacement. Andrea has come in and saved the day. We actually had a couple of those this week. And so we're going to do a little bit different. We were going to have Gonzo talk about harm reduction, but Andrea's going to talk about family systems for us a little bit. So we're going to do that, and hopefully, fingers crossed, we'll get Gonzo to come back in July. And then Elizabeth's going to do a case presentation. So Chris, is there anything else we need to do before we turn it over to Andrea?
No, we can just turn it over to Andrea, and yeah. And you should be able to share your screen.
All right, let's see here. All right. All right, everyone can hear me okay?
Yes.
Okay, good deal. All right, so again, I'm Andrea. I'm in the department. For those of you who don't know me, I'm a family therapist in our clinic. Prior to that, I worked in the research side of the department on adolescent substance use for many years. For about 20 years, I focused on adolescent substance use before I kind of moved more into the clinical side of things. So I'm jumping in a little bit last minute here, and so please excuse, I kind of tweaked some slides from another thing. I've got way too many slides than we need to go through today, so I'm going to whip through them kind of quickly. But we can, jump in, ask questions, and that kind of stuff as we go. I have this bridging the gap because I think in my experience, I found sometimes when we get started with a patient, we get kind of this perception of what's going on from the patient's presentation, how they, how they represent themselves. And then once we kind of get that family system in, we start to get another perspective. It's like, oh, wait a minute, we've got a little bit of a gap here. So hopefully some of this information will help bridge that gap to help best meet the needs of the patient and the family. Primary things I just want to focus on today is like, how do we really start to recognize that role of the family as we're addressing adolescent, and I'm using adolescent youth kind of interchangeably. So I'm really looking at that whole, I don't know, what, 13 to 24, 25, that whole adolescent young adult stage when I do that. I also want to talk a little bit about the interaction between mental health and substance use disorders, as well as talk about a few strategies to help assist parents and families who are dealing with substance use disorders. Let's see, and so let's see. Now, oh, there we go. So again, like I'm kind of a visual representation kind of person. So I love this picture, first of all, because I would like to be wherever this is. But also just because I think, standing on a bridge is kind of like, there's this solid ground behind you thinking, this is my solid place. Like I have this sense of, where do I need to go with this patient? They have X, Y, and Z. This is what I need to tackle. Or I know this research, this is how I need to do this. And then so often that can be derailed and take us to another place. And so we don't always know. Sometimes I feel like we go down this bridge and we get to the end and we're like, oh shit, now what kind of thing. And so, like I said, I hope today is kind of an avenue to kind of help take this in one more direction or extend this bridge at least a little bit. When we look at the role of family in youth substance use, you guys all have your own backgrounds with it, clients, patients that you've worked with, all kinds of stuff with it. So I'll be really curious to hear how this has gone for you. But when I look at substance use disorder, and again, I'm using that very broadly, but it really is, it's often said to be a family disease. And quite honestly, that's why I went into family therapy, because as I was working on all this research on adolescent substance use, I saw such a huge interaction with the family members. And like, okay, I need to go into more of that family role of it. And it's really bi-directional, right? I mean, you can see oftentimes the youth may be using, they're going to withdraw, act out, they're going to, maybe school is dropping, they're moving out of, activities, that kind of thing. And then they get anger and disappointment in parents and family members. And then we have the cycles and the kids, often respond by using more or, just kind of that rebellious kind of thing. So we have that aspect of it. And on the family side, we've got, genetics, family stressors, modeling behaviors, coping mechanisms that promote the risk taking in the youth, as well as experimentation, and, if there's substances around in the house. So there's so many different ways to look at this. And it's really not, the research doesn't have like a clear causality, of course, but we really see this bidirectionality in not only the use itself, but also in the recovery process and helping people heal from it. So I think that's another important part to keep in mind. And when I look at this, and when I was kind of thinking about how do we start to attack this, I think I think our first step is really starting to be curious and understand where are the families' starting points? Where's that land of the bridge where they're standing? That solid point for them. So I think as we go through this, it's really helpful for us as providers to slow down and think, okay, we need to figure out what is the family understanding of, number one, adolescent youth behavior. So oftentimes I've seen, and having my own young adult kids, there's times when, my son's 6'2", he's taller than me. He looks like a man. And sometimes it's hard to remember that, oh yeah, he still is not fully developed. He still has not had the same life experience. And so I think so often as parents, we make assumptions that they know this stuff. But so as providers, I think part of our job is to help to slow down and help that family understand adolescent behavior, brain development, remembering that there's going to be less than optimal planning. There's going to be poor judgment at times. There's going to be more risky and impulsive behaviors. So it's kind of, how do we help ease the maybe angst? Is that the word that parents might have? Why are they doing this? Why did they do this stupid stuff? Some of it might be mental health, some of it might be substance use, yes, but some of it can also just be where they're at developmentally. So that's one aspect of meeting the families with where they're at and getting started on that. I love this quote. This is an old one by David Walsh that I just think is so powerful that, and I like the visual to share with parents too, of it's just like fully functional car. The gas pedal works, but the brakes have not been fully installed yet. So just kind of remembering that really can happen. So a family understanding of adolescent behavior, the other starting point is to think about where is that family's understanding of substance use, of drugs in general. A lot of times parents come in with their own understanding, personal history, fears about substances in general. And so being curious with the family about where do you guys stand with this kind of stuff? And part of that understanding is helping them know too that drugs, including alcohol, have different effects on youth than they do on adults because of that brain development piece of it. I've had patients in the past before where, and even currently, where parents are like, well, when I grew up, I always smoked weed and it wasn't really a big deal. So I'd much rather have the kids smoking weed or drinking alcohol at home with me than out with their friends. And that's a common approach that I hear a lot of families take. And again, I'm not coming at this as a judgmental thing. It's like, where are the parents and what's that family dynamic? And so that's a big part of our helping the family, of understanding that, and then helping them see, okay, here's what we know. How does this fit into what you know too? So, experimentation is not uncommon and it can still be dangerous, especially to the developing brain, and especially considering, various mental health struggles. And that the younger the age of initiation, so the first time they use, then the greater the risk is for a more severe substance use disorder down the road. Few other things on substance use, because I guess I don't know where you guys are all at with your knowledge of substance use. So my apologies if this is getting redundant to your own work, but things that I think are important, because I think our presentation as providers also influences that emotional response in the families. And if we hear, oh my God, they're smoking weed, and we're getting freaked out, then that's going to amp up the family. So looking at, like, we need to regulate our own kind of reactions to that. And remember that use happens on a continuum. Sometimes if, they're just, there's no use or no consequences, we want to tailor our treatment approach to more of that prevention area. And as that continuum of use increases and we have much more severe use or higher consequences, it goes all the way up to, inpatient or residential services. Again, our presentation, the language we use around our patient substance use or the family substance use plays a huge role. In fact, this is a bit of a sidebar, but even the word addiction holds so much stigma and history behind it. So even, watching what you say with that, parents or families will often use the word addiction. I generally try to not use that word if I can, and use it more in that substance use disorder, and keep the substance use disorder as more of a mental health lens than this is an addiction and a behavioral lens, even though there's of course overlap with that, but we can get into more of that if there's questions on that too. And again, I won't go into all of this. I'm not, looking to make everyone be, like this diagnostic, LADC, rule 25, we gotta, here's the criteria and everything. But I did put this in as just kind of a reminder, even as we're going through kind of our own kind of understanding of where the family's at, where the kiddo is at, all that kind of stuff, questioning kind of how is this affecting their life? How is this affecting their work, their school? How is this affecting their social or personal problems? Are they using in situations where it is really hazardous? Are they driving while they're using? Do they work in construction and they, like to get high before they're, driving the I don't know, construction vehicles, any of that? So are they using in difficult or in hazardous situations? How strong are their cravings, their tolerance? Are they complaining of withdrawal symptoms? Are they talking about how, gosh, I'm really trying to cut back, but dang, it's really hard? Or, I was going to quit, but that only lasted a day. If you're hearing that kind of language, like, okay, yep, there's a criteria that we're hitting into. Are they using, are they seeking out substances in a variety of ways? So not just going to buy it, but like, hey, stealing it from, grandma's cupboard or whatever. And is it interfering with our activities, and are they using despite health problems? So those are our criteria, which are now, they used to be called abuse and dependence. Now with DSM-5, we look at it again on that continuum. So two or fewer symptoms are considered very mild, and that's where we would do more of a prevention type of or even like a very early intervention type of approach with that. If we have more than 3 to 5 symptoms that they're endorsing, then that's when we're going to want to look at more of a brief intervention. And then 5 or more, 6 or more symptoms. I can't remember exactly the cutoff, but a lot of it depends on a lot of other stuff too. But we want to look at more of a more formalized outpatient or inpatient services. But anyway, so oftentimes when I'm talking with the kids, it really doesn't matter as much that, that criteria kind of thing, more as how much do they recognize it's a problem. So the cage is a common one. This isn't diagnostic, but it's something that I often give families to say, or give patients to say, okay, how do we know when we're having a problem? And this can be kind of a guideline to say, okay, maybe I'm drinking too much or smoking too much or whatever. And those are, do you feel the need to cut down? Have you ever really felt like time to cut down? Have you felt annoyed by someone criticizing your use? Have you felt guilty about using? And have you felt the need for an eye opener first thing in the morning? That's usually like an indicator. These are indicators that this might be moving into that problematic range. Quite honestly, I've used this with kids too on video gaming and other types of struggles that they might have. So it's not a tool for diagnosis. It's not a treatment tool, but it's more kind of helping them tap into that motivation to change. Like, okay, is this a problem? I won't spend a lot of time on this either. This is actually an old graphic, and I haven't found a new one. So this is like 10 years old now, 9 years old now. But I think, when you look at the data, there's not a new graphic, but the data, what this is doing is it's showing how as perception of harm goes up, so when people look at a substance as more harmful, like this is going to do damage, I'm going to get, lung cancer, blah, 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 then the use goes down. So the red is the perceived harm and the blue is the use. So as we see this with, here's, cannabis. So here's smoke and weed. As that harm, the perception of harm, like weed is really bad back in the 90s, then the use dropped quite significantly. But as that risk of harm, and people started saying, oh, it's not a big deal at all, as that risk of harm goes down, then the use increases again. And now that there's been legalization in multiple states and everything, we're seeing this has actually crossed, if you look at the numbers. So the perception of harm is way down and the use has gone back up. Risk and protective factors. Again, I won't spend a lot of time on this, but I just threw it in here to think about, how do families help to shape the teens or the youth perceptions? And usually it's through our influences on their risk and protective factors. So, as we're working with families, how can we help families increase their protective factors, feeling connected and valued? It's often said in substance use treatment that the opposite of addiction is connection. So, being connected with people is a really important part of that. High educational goals, bonds with social institutions, family involvement, clear expectations, disapproval, supervision, blah, blah, blah. We go through here, and risk factors. And the way I often to present this with families, because I put this out at one point with a girl who I think was like 17 or so, and she looked at this. I had it on a piece of paper and she looked at it and she's like, dang, I'm screwed. I've got like every single one of these. And we continued talking about it, and I made the analogy of like a card game, you know, like this is the hand you're dealt. Absolutely. And let's look at what are the things that are on this risk factor list that you can change. I mean, obviously you can't go back and change when you first used, but can we change your ability to cope? Absolutely. Can we address some of the depression, anxiety, and other mental health struggles? Absolutely we can. So looking at it as like, how do we strengthen our hand and increase the protective factors and reduce those risk factors? And again, I'm gonna go through some of this. You guys are probably aware of. There's higher risk because of the brain development, highly motivated by peers. This is an important one, I think, especially when we are looking with mental health, when we integrate substance use with mental health disorders, is risk of substance use and problematic use increases at times of transition. So when we think high school to college, middle school to high school, divorce, moving homes, all those types of transitional type pieces, that risk goes up. And so something to think about again from that family lens is conversations to have if those types of things are happening. And then, oh, this is just delaying the onset. So again, going back to the brain development piece, what the data would show is that every year that we can delay starting using substances, so every year we can delay, you know, then our likelihood of having a substance use disorder, a more severe substance use disorder, goes down greatly, 6.5 more times. And I don't know if I said that very clearly. So if someone starts using substances, you know, at an early age, their risk of having a full-blown substance use disorder in adulthood is greater than people. I think it's, I can't remember the exact data, but people who wait to have their first experience with any substance use, they wait until like after they're 21, 22, their risk of having a substance use disorder goes down to something like 1% or something like that. So we want to, you know, push that off as much as we can. Okay, so we talked about family understanding of brain development or adolescent development, family understanding of drugs. We also want to get a sense of where is the family's stance and attitudes and knowledge about mental health. Oftentimes a parent's own mental health disorder or their own struggle with mental wellness can lend to rigid thinking in that, you know, my experience is the same as yours. Oh, I had depression when I was a kid, so you're fine, you know, you can deal with this. Or, oh, I still have anxiety. All you got to do is, you know, smoke weed and that'll go away or whatever. So we have to be careful of what those family attitudes, knowledge, you know, how that is all incorporated into this big picture. There's also oftentimes a history of stigma. A lot of times, I think it's getting better. I hope it's getting better. But I think there's still, especially in parental generations, there's very much a stigma about substances. You know, we even see that in our confidentiality rules. You know, I think about how we have confidentiality on mental health and physical health, doctor appointments, all that kind of stuff, but it amps up. Like you have to go through so much more. There's much more consequences if we talk about, you know, confidentiality around substance use. And in some ways, I'm like, that kind of further stigmatizes it. Like, oh my God, we can't talk about it. It's like Voldemort or something. But it's talking about it is I don't know. That's my own bias. I'll be quiet on that part. But there is a big stigmatization of substance use. And and that parents can really, really get caught up in. So starting to understand that, where are the parents and the family members with that? Because if the parents have that belief, a lot of times the kids will also, they're still kind of discovering their own belief around it. But you want to kind of gauge where that's at. And a lot of times family is still learning about their young person's mental health diagnosis. And so I know I've had patients who, kiddo is diagnosed with, say OCD, and they're like, oh yeah, well, they just struggle with washing their hands too much. We'll just get on the medication and this will be fine in about a month or so, and years later, like, oh my gosh, I thought this would be done by now. And so, parents are still kind of learning about that too. So these are all factors to kind of keep in the back of our minds as we work with a family. This is all kind of going in this messy soup of dealing with it. When we look at that interaction of substance use and other mental health disorders, I love this picture because there's just no clear direction. It's up and down. It's not a linear process necessarily. It's up and down and all around. So as we look at that, the causality and directionality is very difficult, if not impossible, to ascertain. We've got, like 60% of kids who are in a substance use treatment program, they also meet criteria for another mental health disorder. And actually that number seemed low to me. But it's old research, so maybe it is low. But then, we also have research that talks about how, well, early drug use might be a risk factor for the onset of various other mental health disorders. But on the flip side, having a mental health disorder as a child might also, some of the research says it also increases the risk of drug use and development of a substance use disorder. So we just have a lot of mixed messages in what this really, how this looks like. Our science isn't quite sophisticated enough to really be able to share how this works exactly. We have the self-medication theory that people are sad, depressed, trouble coping, and so I'm going to use drugs to, cope better, which is certainly accurate in some cases. So that directionality would say mental health precedes substance use disorder. On the flip side, we also have, brain activity, mental health disorders, increased cravings, risk-taking, that kind of thing. Or even, like in the example of psychosis and cannabis, there's been research on that, as I'm guessing you guys know too, of how well in that case, the drugs precede the mental health disorder. So there's just a lot of unknowns in the research world on that. And again, this is kind of another, presentation of that. So this top line here, this blue line, is people with severe mental illness, meaning that they have significant functional impairment that interferes with one or more life activities in the past year. So they're in treatment for a mental health disorder, but they find that over a quarter of them have a substance use disorder as well. And similarly, of the people who have a substance use disorder in treatment for a substance use disorder, they find that, just under 20%, the research has found that just under 20% of those people also have a severe mental illness. So it's a lot of overlap. The comorbidity is quite high. I think where it really becomes problematic is that our treatment approaches, and this is my own little soapbox for a second, our treatment approaches say they are for co-occurring disorders and that kind of thing, but really when it comes down to it, we really see that less than 20% of substance use disorder programs and less than 10% of mental health treatment programs have the capacity to really serve both, to really fully address that dual diagnosis kind of thing. Plus, there's lingering bias about substance use. Or there is often a lingering bias in substance use treatment programs against medications. I've had several treatment facilities reduce or refuse admission for kids I've been working with because they are on Suboxone, for example, or other things. So it's an interesting kind of dynamic of how that bias goes throughout policy and throughout our different treatment approaches. Okay, so whipping through here, strategies to assist families. I'll go through this kind of quickly. If you have questions, I can always give you the slides later too, but I think some of the most important parts is just how do we present with the kids? Again, opposite of addiction is connection. So how do we communicate and connect with them? And these I also bring up with the parents. This is really hard and really important for parents especially, but using that non-judgmental language. Focusing on the protective factors, gaining perspective. What's their understanding of substance use? What is their understanding of their own mental health disorder? And so how do we help to kind of broaden that perspective and help them understand? And not understand necessarily just from our viewpoint, but understand that there's more ways to look at this than just one. Facilitate opening and accepting conversations. This first one, the non-judgmental language, I think that's probably the hardest for most parents because there is judgment around it. There is a desire, I didn't want you to use that, or, that's not going to help you, or, so a lot of that judgment is being put out there, and not necessarily, in a demeaning way or like really poking at the kids, but it's just kind of a family's own feeling about it, and that's all very, very valid. And so it's really quite difficult to navigate all this, but as much as we can as providers really help parents recognize how they can communicate more effectively with their teens, and just open that door is a big piece of it. Oops, and now, there we go. Offering information instead of preaching too, that can be hard. Shaping perceptions, I'll go through this. Ask the non-judgmental questions, be curious, roll with resistance. If they tell you where you can go and how you can get there, okay, I hear you, I'll back off. I'll roll with that. I'm not going to fight back, but let's roll with that resistance. And then when they are in a more open and curious place themselves, that's when we can jump in and say, hey, would now be a good time that we can jump in and talk about this. You say, they think. This is an important concept, I think, to remember, because when we look at communication, and I do this with couples therapy, I do this with all kind of interactions in communication. If we think about when I say something, then I have this ... I say something and you think this, that ... represents a filter that we all have. That is our cultural background, our age, our experience, maybe our trauma history, our mental health diagnoses. So whatever I say, the person I'm talking to is going to filter it through their own lens of everything I just mentioned. And so they're going to think what they think. So if I say, hey, how was your day? One person it might go through one person's filter, and they're going to think, oh, they're curious about, how my day is going. That was really nice. Another person might have a different filter, and I say, oh, hey, how was your day? They might hear, oh my gosh, they're into my business. They're all about my privacy. They just want to, figure out how to get to me, so it might be a totally different thing. So remembering that communication is so important, and everyone has a filter that they're looking through. So whatever we can do to be as non-judgmental and to really respect that filter is an important way to get through to them too. And then respecting that confidentiality. And this can be a difficult one with families, and I know I'm at time, but I'll finish this with the last one here. Especially with youth, because again, that substance use is such a highly protected information. So yeah, it is really tough to navigate with the families, especially when the families want to know, well, what was the results of their drug test? Or, you got to tell me, or if they're using weed, I got to know that because I got to give treatment. And so helping to adjust the parents' own emotional state too, regulate their emotional state too, and reassure them that I get to see a lot of this, and if I'm concerned, I will be sure to break confidentiality when that is necessary. But right now, I can't do that. And we can talk more about confidentiality if people have questions. And yeah, so I think I'll just go through all of these. Yeah, I can give you a few if you guys want, but I know I'm at time here too, so I want to be respectful of everyone's time. Yeah, do people have questions, or what would be helpful?
Let's open it up for some questions. I think would be great.
Okay.
This is a chance to ask Andrea any sorts of questions, because I certainly know I have a couple if folks don't, but I want to open it up and see, this is your chance to ask. Many of you that are on the call work with families. And so is there something that's come up or something that you saw in the presentation that might be helpful to ask about?
I guess something that you had talked about, the concerns that family can have and how that can slip so easily into judgment or feeling like judgment, and that can create barriers. I think the other side of that coin is sometimes when families have a very lax perspective, are normalizing themselves of substance use, and then in trying to provide that non-judgmental education to families for them to be able to support their young person can be challenging. I know I've worked with a lot of families where substance use is present in the household and the young person is wanting to make some changes, and that's exceptionally hard to do when you're around those things and you're exposed to it all the time. And families sometimes aren't always very receptive to changing their lifestyle practices.
Oh, hands down. Absolutely. That happens quite frequently. And that's really kind of that earlier stuff I was talking about, of knowing what's the family's understanding and where are they at, because that is what kind of shifts our treatment approach, our how we address or help them address the issues as well. So yeah, hands down, I agree. That happens quite frequently.
I'm kind of curious on that same front, because I actually had something come up similar to that. And I also thought about this when you showed the graphs of the risk that people have around cannabis and the use, and as the risk decreases, that use increases. And I had an IRT clinician tell me that she was providing some basic education about substance use problems. And this mom who said she encourages her son to use cannabis because she thinks it helps. And the son is actually open to changing. And when she tried to provide some basic education, the mom really got very irate about this, because this is helpful. She sees this as helpful for her son, and son may not always agree with that. But what happened, and I think where the clinician was struggling, was mom's pushback was so intense, which to me signaled that there's something around mom's beliefs about this that she's really struggling with, right? But it was so intense, it fractured some of the relationship. And I'm curious if you have any suggestions when we bump up, because when I feel like that bump in relationships like that, I know it's because there's some strong belief that's typically driving it. What are your recommendations? Because we're dealing with this public information and
Yeah.
attitudes that have changed.
Sure. Yeah. No, I agree. And I think part of it too is that's where us as clinicians, we need to kind of, check ourselves and our own kind of judgment and bias on it as well too. And I would actually take it away from the cannabis itself, because there are some very, very, very strong emotions on both sides. And take it away from that and looking at it from that adolescent developmental perspective, which is almost a safer topic. It's safer in the sense that it's less controversial, and it can open up that mind to see other stuff, and not to say that, well, they can't smoke weed because, or they shouldn't smoke weed because of that development, even though I might believe that as a practitioner, but I want to present it in a developmental way, as far as, okay, your child is on the cusp of adulthood and is really kind of learning to spread their wings. What do you think might be helpful for them to start to make their own decisions? And yep, I hear that you see this treatment approach is really quite effective, and so that's one way to look at it. How do we let so-and-so make their own decision, or, what would be helpful in helping them make that own decision, and really teaching them how to be an adult and how to navigate their own medical care. Because I think that's a big part, as we're teaching kids to be adults. And so I would actually even just shift it away from the drugs, because you're not going to change the mind. And that's not going to help the situation at all.
No.
So that's kind of how I would personally. I don't know, would others do it similarly, or how do others address that too?
I like that approach. Just because it's in your example, Piper, it seems just so evident that mom was taking that very personal for herself. And so I like that shift of, or like finding that distinguishing between her and our youth client. And so focusing on that adolescent piece, I like that approach. I have a client in my mind where it was kind of the opposite of that, where parents were very, very, very strictly against marijuana use, and this kid was not going to stop, and it became quite dangerous for him. And so I was trying to take with the client as an IRT a harm reduction approach, along with education, and that served. Still pretty difficult with family, because it was just such like such a strict budding that there wasn't really room within the family to do harm reduction. And I think this approach would have worked with that too, of like focusing on this adolescent stage of change, of like finding themselves and like taking it away from the drug, but more on like, how are we going to support this client in making like their decisions, and more so like in being safe.
Mm-hmm. Yeah, agree totally. That kind of takes the shift off that emotional, that highly reactive topic. And not that I want to avoid emotions by any means, but it's at the same token, we lose the rationale and the logic to have an open mind. So that's where we need to kind of step back and let that emotion settle a little bit.
Well, and that's where this clinician was really feeling stuck, and many of us feel stuck when we butt up against that. We're trying to do right and provide the right information, but when they're defending it that fiercely, to me, it really suggests that the rigidity is really sunk in.
Exactly.
So this is actually I find this really helpful. I'm going to provide that information and feedback to her. So just going to say, I'm going to take that back to her.
Oh, yes, please. Yeah.
Orly, you had a question.
Morning, folks. Sorry, I joined about 10 minutes late because of traffic. Orly Haven, family clinician at Navigate. What you guys have been talking about recently has made me think about something that I frequently find opportunity for improvement for myself. And that's in both directions that we've been talking about, trying to assist family with setting boundaries and having expectations and clearly communicating expectations to their family members. And sometimes it's setting boundaries when the family is perhaps too permissive or encouraging of substance use, and certainly can go in the other direction when family is exceedingly rigid and not supportive of something like a harm reduction approach. And I'm sort of thinking about the challenge where I oftentimes run into almost a passivity, or where the family members are really looking to me to inform them and dictate what their expectations should be. Obviously, I don't do that because that's not okay in a variety of ways. But I've been, talking about that in my own supervision, and would be very curious to hear if anybody else has some thoughts about how to approach that collaboration with families in setting expectations. And I hope that's not too much of a sidetrack. I think it just seems relevant.
No, I mean, I think that's a critical piece of a lot of this, the family lens, because you're spot on, is that we can't necessarily dictate, this is the rules you should have in your house, because again, they have their own backgrounds, beliefs, and everything that, are okay too. I think, again, how I would shift that is to look at the family values and what's important for you to, as a parent, as a caregiver, what's important for you to see your, child grow into. Do you want to, see them as having, a successful job? Do they have to go be a doctor? Or, what does that mean for you, and how do we support that? What are the baby steps to do that? And the hard part about boundaries that I find in working with families is that a lot of people will say, well, I told them boundaries. They can't, smoke weed in my house. The problem is that boundaries, number one, are communication, or figuring out what your boundaries are. Number two, it's communication. And number three is boundaries. No boundary is going to work if we just let it slide. And that's where I think a lot of the families that I work with anyway, that's where it really falls apart. And so how do we really maintain those boundaries? And the analogy I often use for boundaries with families is, if you invited someone into your home for dinner and they ended up throwing food all over the place, they broke your dishes, you probably wouldn't invite them back for dinner anymore, because you'd set up that boundary. And you may be hurt and frustrated and angry for a while, but you may down the road, still have conversations with them, but you're not going to invite them for dinner anymore, at least not for a long time. Same as like with boundaries for kind of emotional and mental things. Like if people are violating that personal space, that personal boundaries, for some reason we don't have that same kind of, we still invite them in. So how do you help say, you know what, I love you, and no, this is not okay. So that's where I think I would focus on that boundary piece of it. Like, what's that follow through piece, and how are you going to do that? I don't know if I got off topic with that, Orly, but hopefully that is a little bit of direction of one way I might handle it.
Yeah, it's definitely been part of conversations with many folks. I have a specific example of a family who has a young person who is an adult who uses meth, and the family was allowing them to use the car that's in, mom and dad's name while actively using meth. And, they were very passive and saying, well, shouldn't we keep letting them use the car? Because like socialization is important. And I had to do a very baby steps walk through, do you feel comfortable with somebody actively using meth driving your car? Yeah. Is the recent automobile accident an indicator in any way about what you should do about it? And it was a surprising conversation from my point of view.
Yeah, definitely. I've had those conversations as well, and it's and it's tight. You don't want to shame the parents. There's no easy way to parent. There's no right way to parent. But they're not getting the results they're looking for. So if you keep doing the same thing, you're going to get the same results, right? So how do we mix that up? And is often the approach that I take.
Thank you.
Yeah.
All right, I want to give Elizabeth enough time for her case presentation, but join me in thanking Andrea for jumping in and such a relevant topic. I think we could have gone on for a bit longer with some good questions. So I really appreciate it. And I know people would be interested if you're willing to share your slides.
Oh, absolutely. In fact, I think I already sent